Welcome to Columbia University's What is Global Health podcast. Today we will be talking to Dr. Angela Aidala, an associate research scientist at Columbia University's Mailman School of Public Health. She was the principal director of the Frequent Users of Services Enhancement Program, also known as the FUSE program, which is a supportive housing intervention for homeless populations with multiple episodes of incarceration. She is also the co-principal director and study director of the Community Health Advisory and Intervention Network, or CHAIN project, which is an ongoing study of people living with HIV in New York City. Dr. Aidala, thank you so much for joining us today. I thought we could start out the episode by hearing a little bit about your background.
Sure. Well, I am a social scientist. I have been here at Columbia continuously since 1989. I was on the faculty at Rutgers University prior to that. I have my doctorate in sociology here, long ago and far away, and have been interested in urban issues, have been interested in processes and mechanisms of social exclusion, economically, socially, culturally, etc. I think that the issues around social determinants of health, as a sociologist, that's what we learn.
Can you tell us a little bit about the FUSE program and what inspired you to work for better housing and reintegration opportunities for formerly incarcerated people?
Well, again, the extent to which housing, more clearly than other domains or other social determinants, is very clearly for persons with criminal justice histories a result of deliberate human policy decision making that creates a context that is again pathogenic, if you want to think about it that way. The extent to which, if we think about it as an epi-person, right? We know that mosquitoes cause malaria, or the microbe that there's a microbe that causes malaria that's delivered by the mosquito. And it's the same way. A lot of the kind of pathogenic influences in social context are really brought to bear to individuals by where they live, where we live. I like the structure of intermediary determinants of health because, again, I think it's point of intervention. We can't address poverty, exposure to violence, just material deprivation, food insecurity, in early life experiences. But whether people have safe, secure housing in a positive residential environment, whether they're living in a situation that has health-promoting or health-threatening resources, is a matter of policy, political, and individual decisions. So it's a point of intervention, I think. And I also, the work that I do is I'm particularly interested in hidden and harder to reach populations. I put that in quotations because they're not hidden and harder to reach from themselves. They're hidden and harder to reach from us in academic research or clinical research settings. And so persons who are homeless, mentally ill, substance using, street-involved young people, persons with criminal justice history, are more difficult to include in research, more difficult to include for overtime research because the transiency and the challenges, and often then rightly, the institutional distrust. But that doesn't mean that we shouldn't figure out how to involve them, how to include them, how to have our research be informed such that we can find out, learn more, design response, and work with advocates, work with affected communities to facilitate doing research that has some potential to inform, advocacy and policy. I'm not the advocacy person. I grew up. I spent a lot of time in the 60s, being politically active in terms of social movements. I'm very good at painting posters. But there's a role to play, I think, increasingly for academic research to partner with advocates, to partner with providers, to partner with, to provide evidence, if you will. I mean, housing is a human right. Food, it's kind of an outrage that we have to show that it's cost effective for children not to be hungry, or persons not to be homeless. But if that's the currency in the current political environment, then that's the work that needs to be done. And the work that we did with Fuse was targeting individuals with multiple episodes of jail and shelter involvement. And they, our colleague here, Kim Hopper, pointed out decades ago that a number of people are in an institutional circuit. They go in jail, they're in detox, they're inpatient, they're on the street, they're in a homeless shelter, they're back again. And none of these systems really address, it's a huge human and social cost. And so there's increasing attention to looking at what are points of intervention and how might that cycle be addressed. And in the whole area of housing and housing services, the model for decades was people had to be ready for housing. They had to be abstinent. Their substance use had to be under control. Their mental health issues, they had to be adherent to mental health. And time and time again, that doesn't work as well. As many people I've interviewed says, well, if you don't have a place to live, right?
Right. How can you achieve that?
How can you exactly?
Yeah.
Place to live is a place to begin. And at the federal level, there's been a kind of ideological back and forth that housing resources are always a political football because housing is expensive. So why should we give housing resources? My son and daughter, they can't pay the rent, or find their own place. They're living in my basement, So why should we give housing resources or make housing more affordable to people who have these histories of bad behavior, et cetera, et cetera? But the housing first model, which is, as you probably know, placing people in housing with services, is much more effective in getting people stable in their living day-to-day lives, having a place, in fact, where they can receive services, being connected with a structure of services where someone can actually, check up on them, if nothing else, right?
Right.
Makes a huge difference to individuals and to into systems. The other thing that's of interest is strengthening our ability to make inferences, convincing inferences regarding effects of interventions with non-randomized designs. Are you going to randomize people to be in jail or not? Or stay homeless on the street and see what happens if this one gets housing and this one doesn't? So, there have been attempts. I don't know how much you want to do statistics, but, I think as policy folks, they had that lesson in high school about random assignment, right,
without sort of concern for the humanity of the person.
Well, I mean, there's a notion of it, but the point is that it's classic. You can't, if you design a piece of research that meets all the rigorous requirements of RCT, right? First of all, it can't be blinded. If you get housing or you stay in a homeless shelter or not, it's not like anybody's blinded. You are not blinded. The interviewer's not blinded, right?
Right.
Number one, for one. And secondly, it is unethical to just, there's the equivalence. There's a lot of principles, ethical principles and otherwise, that, you can't just let people, again, stay in a really dangerous or unhealthy state while you see what happens. Plus the fact that people don't hold still. They will do their best to continue to get housing. It's the same with a food program or a work program, right? People don't wait, Plus, if you put more resources into a jurisdiction, let's say more housing resources, because you want to test if this model of housing is going to have an effect, you've created then more resources in a system. It's a vacancy chain, as they talk about statistically. And so then people get resources. Every housing intervention that has attempted to implement at least a modified RCT has resulted in a tremendous crossover, meaning that over 50% of people in the comparison group are in housing similar to the intervention housing. And guess what, right? Statistics enough to know that means that then your outcomes, you don't have that. You don't have much difference. You often don't have much difference, right?
Right.
And it depends on what you think the causal juice is. If the causal juice is actually being in the housing, right, then people are getting a treatment or an exposure, right?
Right.
That's very comparable. Maybe there's an additional package of services or therapeutics. I'm not saying that there aren't differences in packages of services that can be attached, but if the causal juice, if the real huge difference is not the therapy and not the case management, but actually being stably housed and having a sense of place and home and being able to begin building your life again, then it becomes very hard. So it's incumbent upon us, though, us researchers, to learn to make stronger, to take advantage of others. I'm not a statistician, but I work with them, right? So because it's the same thing. What we're seeing in, for example, epigenetic, you can't randomly assign people to a certain genetic background, right? There are a lot of things where we're really looking at conditions under which we can strengthen inference about effects, right? Using quasi-experimental designs. There's also the efficacy versus effectiveness. The other thing that happens, again, with a number of housing-based interventions that I've seen, that I've been involved in, CDC, HUD, et cetera, is that, you want to have it tight, you want fidelity, so you bring in trained people to deliver the intervention, and you provide, again, you enhance resources to these already over, demand. That's not the real world situation. So the issue of generalizability also can be compromised. So I think it's important for us to think about, and that's another interest of mine, is looking at how to strengthen inferences. Closely match, using propensity adjustments, using data mining, using certainly multiple data sources, using admin data match. I think it's crucial to interview people. That's another thing that a lot of these government interventions around housing and particularly corrections basically want to look at one thing: reincarceration, right? Recidivism. Well, in a short time period, to change somebody's life entirely, it's very hard to be poor and not get arrested, particularly if you have a history of being arrested, right? Jumping turnstile, vagrancy, public urination, panhandling, being out on the street and looking raggedy, right? So I have absolutely no money. I have, if I have an appointment with my parole officer. If I don't show up, I go back to Rikers. If I jump the turnstile so I can get there, I go back, and I get caught, I go back to Rikers. Wow. So people are caught in this kind of cycle that, again, just constrains their ability even, the context people find themselves in rather than, or interacting certainly with motivation, interest, awareness, et cetera. So anyway, I thought it was socially, politically, policy-wise very significant intervention work. Yeah. One that they had attempted to do, they meaning the team, the providers, the city, to do an evaluation that wasn't based on a multi-method approach by doing in-person, semi-structured interviews as well as data matches, and that didn't have very convincing results. But again, I can critique their methodology if you want. And it also was an opportunity to kind of make some of these, kind of investigate and build the evidence for this methodological approach as well as the intervention as such. It has now been instituted in the city. There's about 16, 17 cities around or jurisdictions around the country that have fuse type, frequent user type interventions.
Mm-hmm.
And so that to me is a mark of, that's sort of my interest. That's my marker of what I think is the kind of thing that some of us should be involved in and doing. So.
Right. Well, it's certainly inspiring that through this program you've been able to sort of go in and understand what's happening with a population that would be so often overlooked, and being able to make a positive impact on their lives.
Well, see, I think that's the issue, and that it is hard, though. Let me tell you, even the cohort study, the chain cohort study, it's hard, and it is more costly, right? Than an online survey, right? So we, at any point in time, obviously, these are people with histories of homelessness who may have an active warrant out for their arrest, who are not, who as I tell my students, because I teach survey research also, you have to think about what you may be good-hearted, really committed, passionate about, right? Helping, but the majority of time that someone has come and asked questions, even these kinds of questions to somebody, is to deny them something, to determine that they aren't eligible for some, benefit, to determine that they're not eligible for the program, or to just document some way in which they have broken some rule or social norm or something. So
yeah,
you have to. But again, there's no reason not to include it. I work with all community-based interviewers who ideally come from communities that have had some shared experience. Again, we talk about cultural competency. I think we need to bring these research, I think people in the community who have cultural competence, they have lived understanding of these issues, these neighborhoods, these populations, bring research competence to them, right, rather than always the other way around. And so I think that's a part of the strength, is that being able to gain trust, establish rapport, have people sit and share issues that once you establish that, they want to share there. Nobody's come and sat down and said, well, what's your life like? And what are some of the issues? And what has been helpful to you? What is not? If you had to make a decision between this and that, how would you use your resources? How would you use your time? Rather than saying, you should, here's a quantitative. We do quantitative too, don't get me wrong. You got to have the numbers, right? But also kind of understanding why housing is one of the biggest predictors that people aren't adherent to treatment regimens, so for HIV, for any of their illness. It's just not. If you're feeling okay, right? Going to the doctor, that's going to take that MetroCard, right? Maybe even if you get one at the clinic, you don't get it until you get there, right? So I think those are the things that people really appreciate, that we are trying to understand. You're not just a disease or someone with a history of criminal justice involved, but what's your life like on a day-to-day basis? And I think that's where the sociology part, humans and social context, social history, what structures the private sphere, are things in my kind of past history, intellectually, personally, that I think kind of bring me to this work. So.
Oh, wonderful! And the approach of just trying to understand the issue through the perspective of the people that are going through it seems consistent throughout your work. I also noticed, I also saw that you're the co-principal director of the Chain Project.
Yes.
And so through this project, what have you found are the primary needs regarding health and human services among people living with HIV?
Well, I think, again, the issues that HIV is an illness, definitely, and certainly people need medical care. They need they need medications. But medications in and of itself, I think, the concrete services such as housing, food, healthy food, believe it or not, transportation also. Because we have public transportation here, so it's less maybe than some other places, but it still costs, right?
It's expensive,
and it's still expensive. And think about it: if you have $2, right, that's what you have. Are you going to spend that to get to your doctor's appointment? Or you're going to eat if you haven't eaten, right? And what are you going to eat with that $2? You're going to have fresh fish and green leafy vegetables, and you're probably going to go to, McDonald's. We've begun looking at that a lot more, the intersection between food insecurity, housing insecurity. These really kind of concrete hardship things that constrain people's lives. One of the biggest predictors of dropping out of care, lack of retention in care over time. In New York, where care is, we have one of the best developed systems for providing care for HIV, with an acknowledgement that supportive services are important as well too. Is housing and stability, housing and security, but also food. But you think about it, if people have 78% of people who are receiving housing assistance, right, are food insecure, because even if they're receiving some kind of housing assistance, it still means they have to be poor enough to meet that threshold. They often don't have, the way our structure of services work, they have, they still have, we need to eat multiple times a day. It's not like once a month you can get a pantry bag. If you get some resources somewhere, they'll cut back your food stamps. You may not be eligible for food stamps. One of the biggest things that we see in our overtime studies is that people are routinely bumped off of food stamps. They can't. Again, there's been some attention under Obama administration and under de Blasio to kind of not have as rigid requirements for recertification. Which recertification means? You get a notice, you got to show up somewhere, you got to prove you're still eligible. Well, again, you don't have a regular place to live. Whatever notice you got, you didn't get it. Can you really get there? Can you spend all day there? So people are just bumped off. They're bumped off, and again, we have systems set up that are not workable, not easily workable. Even if you know what you need to do, you want to do, you're highly motivated, people get themselves into, or placed into situations, contexts where it's very difficult, not impossible to do so. Again, remember, by definition, we're talking about people who tend to be more likely socially isolated, to not have a structure of support from family or friends, or things convenient where they are, where they live, etc., etc. For HIV in particular, and these are things, again, I've learned from my consortium of advocates. There's this Food is Medicine advocacy group that's really trying to press for acknowledging medically tailored food assistance for people with chronic illness, HIV and other chronic illness, that it affects, gastrointestinal. You have diarrhea, you have stomach cramps. That's one of the biggest reasons you stop taking your medicine. If you have diarrhea, the medicine gets washed out before it's even there are physiological, ways in which whatever medicine is just not going to work as well, right? And through the direct physiological body effects, but also through then not taking it, right? And or not, if you don't have money, the affordability issue, if you don't have money for getting something to eat, or feeding your kid, or spending that money to go to the doctor, the choice is not hard.
Great. Well, those are all my questions for now. Okay. Thank you so much for joining us and speaking to the importance of social determinants of health and how these systems can better serve their populations. I appreciate it.
And keep us healthy.